who will present the results of the survey first, and then we will navigate through to the statements, and we will try to find a way of consensus, on the management of a test with genomic sequencing in this patient population. So let's start the discussion, and I leave the word to Valentina and to Antonio chairing this session. Please.
For the introduction, it's an honor for me to be here today with you. And so let's start. We have conducted a survey to explore the current use of NGS in patients with urothelial carcinoma. The survey was composed by two sections. The first section, which is the focus of the main presentation, was open to every GU oncology expert willing to fill the survey. The second section was addressed to a select group of experts, and the results will be presented later by my colleague Antonio. 25 GU oncology experts provide responses to the first section of the survey, and now I will show you the results of the survey. The first question: how often do you use NGS for patients with urothelial carcinoma in your center? Almost half of responders said sometimes. Why don't you use NGS in all your patients? Principally because of economical issues, but also because an absence of evidence supporting the widespread use of NGS in urothelial carcinoma. In which setting of disease do you use NGS? Principally metastatic disease. Which NGS panel do you use in your center? Mainly commercial tests. How many genes are analyzed in your NGS test? The majority of responders utilize a really large panel. What tissue do you use for NGS analysis? Principally FFPE. Liquid biopsy is used only in 28% of responders. Are you satisfied from the NGS panel available in your center? 73% said yes. And these are some points of proposal from the responders of problems regarding the use of NGS. So delivering results, need a larger panel, the value, better test available commercially, limited genes, and so on. Which are the essential informations we need for urothelial carcinoma? All the responders agree on FGF receptor, but there is also a high agreement for TMB status, ERB-B2, MSI status, and homologous recombination repair genes. These are some proposals from a responder, other genes to analyze. And which is the utility of NGS in urothelial carcinoma? Principally therapeutic implication, but there is also some interest for other implications, such prognostic implications and research aims. After all this consideration, in which setting of disease do you think NGS should be utilized? Principally metastatic disease, but there is interest also for other settings. Do you prescribe germline test for patients with urothelial carcinoma? 43% said sometimes. And in which cases do you prescribe germline test? Principal in patients with significant oncology family history, but also in young patients, and based on the results of the somatic test. The final question, considering the balance of cost and utility of NGS, do you think its use is justified? And the majority of respondents said yes. So before starting the discussion, I will show you the current Italian regulation on the use of NGS. The NGS use is suggested only if its use doesn't determine an increment in cost with respect to standard methods. So if you use NGS for therapeutic implication, we have to consider which are the biomarkers with approved drug by the Italian healthcare system. So the balance between cost and utility in a limited available targets should be considered. So some inputs for the discussion. Is NGS adequately used in patients with urothelial carcinoma? If not, which are the most relevant problems that impede an optimal use of NGS, and which are possible solutions? Which kind of panel should be utilized for NGS in urothelial carcinoma, and which are the most important genes to analyze? Which is the perfect setting of disease for NGS application? Which is the role of liquid biopsy? And finally, when germline test should be performed? Thank you for your attention and contribution.
Between United States and European Union is quite different. What is your situation of the possibility of prescribing and using NGS in your country in urothelial cancer patients?
So we are making an effort to send NGS for all metastatic patients when we are seeing them. Unfortunately, in the localized setting, it's still not being done that much because it does not change practice, but I think it's wise to start doing it. The sooner the better, before we lose the quality of the tissue. And we don't have the issue for getting NGS testing. There's multiple vendors and it's covered by insurance, so access is not a problem, but certainly I wouldn't say it is adequately used. We can do better.
Yeah. Jeff, a very, very difficult question to you. What is the perfect panel to use? Besides the foundation one panel, what do you think? In principle, what do you think? What is the best way to handle the gene sets in this patient population?
That's an excellent question, and I'd first say it's not the genes in the panel; it's the sensitivity and specificity of the assay. Meaning, having a broad panel of genes and not having a deep enough sequencing depth will make the harder to detect alterations missed by the test, and they might not have even known. So things like short insertions and deletions and copy number changes can be very difficult to detect in insensitive assays. And if the genes are on the test and you still miss when they're altered, you haven't helped the patient. So after saying that, targeted therapies and targeted sequences usually match quite well. And each disease, though, is slightly different. And the one in genitourinary cancer that I think is the most underutilized is prostate cancer, much more so than urothelial. For renal cell carcinoma, we don't have anything. I mean, it's just sequencing doesn't help those patients at all. But prostate cancer has long been thought not to be a good type of tumor to sequence, and now more and more data suggests it is. And I point to just one alteration that I think is by far the most important, and that's BRCA2. We know it's the dominant DNA repair defect that's associated with sensitivity to PARP inhibitors in prostate cancer. But unlike breast or ovary or other cancers which are BRCA1 dominated, BRCA2-dominated prostate cancer has 20%, 1 in 5, that is not an inactivating mutation in BRCA. It's a homozygous deletion of the entire gene. And why that's so important is that the major mechanism of resistance to PARP inhibitors in both prostate and non-prostate cancers is BRCA reversion mutations. Under the influence of the PARP inhibitor, the originally mutated BRCA gene mutates enough again to produce a protein that restores the DNA repair, eliminates the defect, and stops the PARP inhibitor benefit. But not for the patients with homozygous deletion. They don't have the gene, so they can't make the reversion mutations, so they stay sensitive to the PARP inhibitor for a very, very long time, maybe forever. We really don't know what the length of efficacy is. Let me just one more. 20% of BRCA alterations in prostate cancer are homozygous deletion. It equals 1 to 2% of all men. When you have hundreds of thousands of patients, that's a lot of patients, and they need to be treated completely different from all other prostate cancer patients. They may be put on PARP inhibitors for hormone sensitive, you would think, maybe not even try hormonal therapy, no taxotere therapy, no immunotherapy. All they need is a PARP inhibitor, and it may be good for the rest of their life.
Thank you. Let's assume that erdafitinib is available as a standard of care in European Union. It is not available, unfortunately, in European Union. But if I have a patient with a refractory disease, chemotherapy treated, immunotherapy treated, lymphoma treated, and I have to know whether or not the tumor is harboring any kind of FGF receptor 2 or 3 genomic alteration, what arguments are you able to use to convince me, provided that I am the payer, and you have to convince me to use an extended panel or a broader panel instead of the single FGF receptor 2 or 3 testing? What could be the argument and the value of extending the genomic testing to a broader range of genomic alteration, or including TNB, including other things? How can we convince the payers to be reimbursed with an extended panel test instead of using a targeted test with a specific gene set? Maybe, Iwan, what do you think?
That's a great question, actually. I think probably the best way to do that is generate data. I think having combo therapies with FGFR3 inhibitors and perhaps something else would be the way to sort of approach that problem.
And is there, maybe Petros, is there a way, put yourself in European Union, is there a way we can convince reliably the payers that the patient may benefit from the results of an extended NGS sequencing instead of a single FGF receptor testing in a special setting like a metastatic setting? So is the opportunity to potentially access an off-label use of any kind of approved targeted therapy with an off-label indication, with another indication, is this an argument, do you think, that to convince patients who do not have any other standard of care option to be reimbursed in the NGS test?
Andrea, great question. I will try to answer as a fellow European, as a neighboring Greek here. So I think there is a number of factors to think about. So in the United States, as we know, erdafitinib has for now accelerated approval, and we believe this will be converted to a regular approval based on the Thor trial data. And I expect that the approval will come from EMA as well in Europe. And there has been a companion diagnostic all along since April 2019, when ERDA got the approval in the US. Having said that, I can say I have never used a companion diagnostic. I have always used a commercially available, and Jeff is here, a platform, because I want to have a broader picture of the genomic landscape of the disease. Why this is important? The first reason is that we need to have potential targets for clinical trials. So it's, I think, directly associated to availability, going to help us talk about healthcare disparities, availability of clinical trials that can be informed. We have a number of trials at our center. We mentioned the combo match earlier today, but also phase 1 trials, and also trials in urothelial cancer, for example, anti-HER2 trials that rely on the presence of particular molecular alteration, and unless you don't test for it, you don't find it. So I think that it's of value to have a broader picture of that genomic landscape of the disease. The second reason is, obviously we have used checkpoint inhibitors all along, and now with pembro-EV data, I think we're going to be used more in the frontline setting. Having said that, there are specific situations where a patient may not receive it up front, and obviously pembro-EV is not available in any country. If you are in a further sequence of the disease treatment decision-making, and I think we have the data from Thor-2 trial, and you saw the ERDA versus pembro, and you're in this between dilemma, having the TMB data that Jeff showed might be a deciding factor in a patient, for example, with asymptomatic, low disease burden, no need to get the response right away, so you're not needing a high response rate. Would you use a TMB to impact your decision? Potentially, to decide between ERDA and pembro, for example. That's a small slice of the pie, but relevant. The third thing is, rarely, you may see in this disease, very rarely, MSI high, and we don't have much data, obviously, for MSI high, but it's a very robust biomarker from immunotherapy response that may also influence your decision. And the last thing the two last points I will make is number four is, if we don't do those gene assays and we don't profile the disease, we don't learn about the disease. And I think learning about the disease is key, and this will open the door for research, and research is the vehicle to promote. The last thing is cost. And if you think that the cost is comparable, why not potentially getting a broader gene assay?
Thank you.
So, Andrea, I just make a point. There was an ASCO abstract last year where there was a study in lung cancer patient population, single gene testing versus multiple gene testing. And actually, single gene testing leads to exhaustion of the tissue, precious tissue, and then they are not available for bigger panel testing down the line. And
that's a great point.
It becomes actually more expensive if you have to do the biopsy again. So I would say, based on the lung cancer data, it is always good to do comprehensive genomic profiling up front so that tissue is there, and tissue has quality and quantity to allow that.
That's a great point, and basically introduces the other point, which is related to the role of liquid biopsy. So Lars, what do you think? Having the possibility to rely on a recent biopsy performed on these patients, what do you think could be the added value, or would be the added value of performing tests on liquid biopsy instead of tissue, or what do you think?
So I definitely think that doing NGS on cell-free DNA for identifying novel targets and mutations for directing treatment, that's very important. I think the disease heterogeneity prompts us to do this. We know that the metastatic disease that we want to treat is probably different from the primary tumor, so I think it's very important to do that, and I think it's heading in that direction.
Thank you. And what is, very quickly, the right timing? That is the other important point, the right timing to test the patient. Shall we wait for the disease refractoriness to conventional therapies, or should we test as early as possible the patients? A quick round to Phil, and to Maurizio, and to Marco.
No, I think Lars did a very nice, compelling, argument. I think the design of his studies are the right way to do this. Is you want to do it from baseline, obviously understand the natural history of the disease early when you're doing it, so that you ultimately know how to use these various, obviously, liquid biopsy, ctDNA biomarkers, and know ultimately the optimal indication and when to do it. And it's interesting, as you presented, Lars, I think obviously this is going to come mainstream in clinical care. To me, it's just a matter of ultimately time. But obviously there's going to be some interesting things that are going to come from this, is we're not only going to understand whether, cutoffs are going to help us understand the biology, but also I think, much like we see in germ cell tumors with serum biomarkers, rate of increase will help us predict, doubling time, like for prostate cancer, for example. We're going to have a very sophisticated ability to use this, including kinetics, to help understand the patterns of progression and when we need to intervene, just far beyond just a simple cutoff.
Maurizio.
Yeah, as you know, in Italy is not a standard, so it was difficult to do it. We use it not routinely, and we have difficulties for this, and also costs is important. However, I would do it as soon as possible. We have a lot of tissue at the very beginning of TUR. This is my attitude that I would do.
And would you change your mind based on the tumor location? So would you consider, would you change your feeling when you have in front of you a patient with an upper tract tumor instead of bladder cancer? What do you think? This may lead to potential different decision making or not at this point in time?
That's an intriguing question. I mean, in my mind, upper urinary tract tumor is a little better than bladder cancer. So I would not so, keen to do it in upper urinary tract, especially in the ureter. And for bladder cancer, I would do it.
Okay, Marco?
So at this point, I would definitely use NGS for a patient where we already know the target and when we have a clinical appliance. But as I said, actually, the tissue of our patient is very important, it's very rare, we should use it wisely. And I think the most important data that we get from it, from research purposes also, is to measure before and after treatment to develop new target, but also to have a new prognostic marker. So if available in the trial setting or if funds are available, I think we'll be very interested to have much more data as possible regarding this topic.
Thank you, great point. Last point that I addressed to you, Jeff, and to you, Shilpa, is related to the role of germline testing. Do you think, or when do you think, that the results from somatic NGS testing could lead or should lead to some kind of germline testing? So regardless of the patient characteristics, younger patients or patients with upper tract tumors, when you may have some consideration on some suspect of Lynch syndrome relation and so on, just relying on the NGS test results performed on tissue, do you think that there may be in routine practice indications to move to germline testing? Shilpa, first.
Yeah, I think if we are suspecting Lynch syndrome, especially in upper tract patients, that is now part of the guidelines by the AUA also, so that is the one situation we should consider.
But starting
germline.
from the tissue results, what do you think?
If it's MSI.
There may be MSI. So do you think that this is the only potential indication by which you could prescribe genetic counseling?
Yeah, that, and also if there's BRCA, even in the urothelial, then I think if you are seeing some of these mutations, then I think you should consider germline testing and provide genetic counseling.
Andrea, may I make a comment?
Yeah.
On upper urinary tract tumors,
let's
okay.
First Jeff, and then you take the mic.
Well, the easy answer to the question is any report you get back that has a mutant allele frequency between 40% and 60%, you should order germline testing. Obviously, 50% means it's germline, pretty much. And of course, it does depend on what gene it is, but we have a list, 17, 20, 25 genes for all cancers, and for urothelial is a separate list for what are the germline mutations that have been described for urothelial cancer, or for prostate cancer where germline is even more important than urothelial. And obviously for renal cell cancer today, maybe not so much if they change the approval, but knowing whether it's familial von Hippel-Lindau, whether it's sporadic von Hippel-Lindau mutation, decides whether or not a certain therapy can be given, although I think we're going to expand that to all of them. So I think there are somatic reports that say nothing about germline prediction, and there are somatic reports which guide the ordering physician when a germline test is highly recommended, and that's what the difference is. Is it recommending you to test for germline? You should do it. If it's not, but you see it should be, then you should do it. Because to miss it not only affects the patient, but affects the patient's family.
Maurizio, last word, and then we'll jump to the next panel of statements.
I was only commenting on when you get the tumor in the upper urinary tract, because sometimes some controversial is if you do radical nephrectomy and ureterectomy, or you go for a ureteroscope and then you take a piece of tissue. The issue right now, in my mind at least, is to challenge guidelines in order to spare the kidney also in T3 high-grade or infiltrating urethral tumors, because sometimes you can have good results and then you can treat the patient without taking out the kidney. And the question is, if I do ureteroscopy, I cannot take a lot of tumors, so I cannot have a lot of tissue in order to check what would I like.
Okay. Okay, so
Andrea,
Antonio.
20 seconds only, 15 seconds, I will just say.
10 seconds.
Somatic and germline, great points overall. Somatic and germline testing are different though. And we can, as Jeff said, we cannot rely only on somatic testing because they're differently inherently, gene panels, bioinformatics, they're different assays. So we have to do germline dedicated testing when indicated.
Thank you. Antonio,
Yes.
you have 10 minutes for the second part.
Okay. Good evening, everyone. Today and now I will speak about the results of the consensus for the optimal use of NGS in patients with urothelial carcinoma for San Raffaele Hospital. So, from October 10th to November 10th, a survey was conducted to establish this consensus. The survey was anonymous and comprised 15 questions utilizing the agree, disagree, abstain method. We established that the question achieving a 17% consensus would not require further discussion, while questions not meeting this threshold will be collectively discussed at the conclusion of the presentation of the survey results. So, a total of 12 experts present at the ongoing Congress, including 7 oncologists, 2 urologists, and 2 pathologists, were sent the survey to complete, and of these experts, 11 provided responses, so the 91%. In question 1, the experts established that NGS should be considered only in selected patients with urothelial carcinoma. In particular, young patients, but also female patients, and also patients with variant histologies, and finally, patients with upper tract urothelial carcinoma. Question 6 needs further discussion later. In fact, when we asked to the experts if NGS should be considered at the moment of the diagnosis or not, there is a trend in disagreement, but not a consensus. In question 7, all the experts are in disagreement on considering only in patients with muscle-invasive disease NGS. But strangely, in question 8, when we asked to the experts if NGS should be considered only in patients with metastatic urothelial carcinoma, a consensus was not met. There is a trend in disagreement, but not a consensus, and this is in contrast with the previous question. In question 9, the experts established that NGS should be performed on a recent biological tissue, and question 10 needs further discussion. In fact, we asked if a disease-specific gen set should be used when ordering an NGS test, and there is a trend in disagreement, but not a consensus. In question 11, all the experts are in disagreement to considering a liquid biopsy in preference to a tumor tissue NGS test. And although the complexity of the topic, in question 12, the experts underlined the importance of the communication of the results of NGS to our patients. Finally, the last 3 questions which need further discussion focus on the indication for genetic counseling for patients with urothelial carcinoma, if they may be influenced by the results of the somatic NGS test. Question 13. Question 14 is focused on the urine-based test and if it is preferable compared to a tumor tissue-based test in selected patients with urothelial carcinoma. And finally, the last questions. In the last questions, we asked if indications for ordering an NGS test should be justified by the accessibility to selected targeted agents. In conclusion, the established points focus on selected patients, so young, female, variant histologies, upper tract urothelial carcinoma, recent biological tissues, and adequate communication of the results. While these questions need further discussion now, and thank you for your attention.
Yeah, okay, so let's see this slide. So we have basically 2 minutes per cake. So Shilpa, first, the NGS considered at the time of diagnosis, regardless of the clinical stage, there is basically disagreement. What do you think?
I think with the landscape changing, with all the work that is happening in non-muscle invasive and upcoming with the muscle, with the pretzel containing erdafitinib, systemic erdafitinib early on, it should be ideally done at diagnosis, and we should be also talking to our urologists who are seeing these patients at the first contact to start thinking of sending it out.
Jeff, NGS only in patients with metastatic urothelial cancer. Would you agree on this?
Oh, of course not. I mean, I only have to sit here at Hospital San Raffaele and see all the contribution to precise use of neoadjuvant therapy in urothelial carcinoma, in which these patients do not have known metastatic disease, but are trying to get a much more precise treatment prior to and possibly not even having to have a radical cystectomy. So it's not limited to metastatic disease only.
What about those who agreed, actually? Because it seems to me that we can achieve very easily an agreement here. Who of you would still think that there is a role for NGS only in patients with advanced disease? So basically there was a mistake on the answers. So you can easily solve this cake. So this cake is eaten, and then now was the best one. So Iwan, disease-specific gene set. What do you think?
I would say 100% no on that one as well. I think you need the whole genome.
Okay, great.
Better. Yeah.
Who is thinking that a disease-specific gene set is suitable for this patient? Raise your hands. No one. So the other cake is solved. Yeah. Much more easier than what I thought.
It depends on the question.
For genetic counseling, actually, based on the somatic test, see, here is there may be some more nuances. Petros, what do you think?
I think it's a great question. I think, as Jeff mentioned before, if you have a somatic report, you may get some sense of some suspicious findings. Obviously, the tumor content and the purity are also factors that may influence the mutational allele fraction. At the same time, I think, discussing more and more with colleagues who do germline testing as genetic counselors, they make the point that I also mentioned before, that we need to have dedicated germline testing and not rely only on somatic testing to make the germline call. So I think more and more in my clinic, I send patients genetics for bladder cancer, urothelial cancer, upper tract disease, based on age, family history, more than one history of cancers in the patient, and tumor location. And I think in the future, we'll do more and more, and probably everybody in the future will probably get germline testing and somatic testing at the time of cancer diagnosis. That's where we're heading. I think it's a matter of time and a matter of cost to get there. So the answer is yes, it can be influenced. If you ask the question, technically yes, but you cannot rely on somatic testing to rule out germline mutations.
Great. Phil, Maurizio and Marco, 1 minute each. What do you think about the urine-based NGS test? Is it preferable compared to liquid biopsy or to compare to tissue test?
So I think that's a really great question, but as we're conversing, clearly we see the opportunities this has in earlier site disease. So as we know, the benefit in bladder cancer is the urine is a great avenue to sort of test. So it's less invasive, and obviously if we have a test that's based on urine, we could follow the patient and do so in a very continual fashion without the invasiveness of necessarily tissue and biopsy. So absolutely, I think that is definitely preferable.
Maurizio?
I think in non-muscle invasive bladder cancer, we have good tests like cytology, when the cytologists are very good. In our center, we have 98% specificity, so it's a very good test. But for muscle invasive, I will prefer tissue.
Marco?
I think that it's definitely what we need, because especially for those patients where we don't have much tissue, so when we want to measure the response after neoadjuvant chemotherapy, for example, neoadjuvant immunotherapy, having a proper urine-based test would be great to find and to make the analysis, while sometimes it's not so easy to get the tissue where to make the analysis on the bladder specimen.
Great point. Lastly, 1 minute each, Lars and Neraji, indication to ordering NGS test should be based only on the availability of a specific targeted agent in a special, at the country level. What do you think?
Answer is no. It should be based on not only the current availability, but also the potentially available agents in the next 3, 4, 5 years. These tissue, so I want to take a step back. First of all, and I made the comment that tissue is precious. Once we use the tissue, it's gone. And it is almost impossible to get another biopsy and wait for the results of NGS when disease is progressing. In fact, as Shilpa showed in our talk, only 50% or less patients actually get any systemic therapy for metastatic bladder cancer. It tells us how rapidly progressive the disease is. So we don't have time to order the NGS when metastasis develop or second line or third line. So I think it's best to get the results up front as much as possible and be ready.
That's great. Lars?
I completely agree, and I think the whole field is moving towards whole genome sequencing. It becomes more and more cheap to do this, and I think actually it's going to outperform the different panels, and you can actually get better representations of the genome by doing whole genome sequencing, because it's technically less demanding. So I think definitely we should do that, and I think tissue is precious, so that would be a way of preserving the information also.
So deal, that's great. So the last cake is solved. So Antonio and Valentina will work on the last round of statements. Based on this discussion, we'll send you for the last review. And I'm ready for politics. So thank you to all the panel for this insightful discussion. And